Hello, everyone. I'm very happy to have the opportunity to present today at the Asia Pacific AIDS and Co-Infection Conference virtually on the topic of role of clinical pharmacology in the management of HIV-TB co-infections. Before we delve into the studies and the drug-drug interactions that occur between antiretrovirals and TB drugs, I just wanted to take a step back just so everyone's on the same page in terms of the type of studies we're going to be reviewing, and they're primarily pharmacokinetic and pharmacodynamic studies. So in pharmacokinetic studies, which is the majority of studies we'll be looking at today, are really just looking at the change in concentrations or drug concentrations over time in the body, primarily in plasma in the studies that we're looking at today. So this is looking at things like the maximum concentration, Cmax, the minimum concentration, or the exposure of the drug, which we use AUC or area under the curve. But there are a few studies where perhaps looking at the pharmacodynamic effect, which is looking at the dose-response relationships, relating the concentration to the efficacy or the concentrations to the toxicity. So again, just the type of pharmacokinetic studies that we're going to be reviewing over the next 20 minutes are really focused on pharmacokinetics and pharmacodynamics. And these are some of the parameters, Cmax, Cu, which we're going to be reviewing. And again, the focus of today's talk is really going to be on susceptible Mycobacterium TB, where, of course, all of us know the four key drugs that are used for this treatment are isoniazid, rifampicin, pyrazimidine, and ethambutol, with a classic 6-month treatment of 2 months intensive and 4 months continuation phase. However, it would be amiss perhaps not to mention this very exciting study that's just been published in the New England Journal of Medicine, which is now really changing this paradigm of 6 months treatment, where and now using a 4-month treatment with rifampicin with moxifloxacin as well, was shown to be non-inferior to the standard 6 months treatment for drug-sensitive pulmonary TB. So now maybe we've actually had a shift for the first time for a long time in terms of these standard 4 drugs for tuberculosis treatment, but still using one of the rifamycins, rifampicin, along with moxifloxacin. So, the presentation I'm going to focus on today is you can expect that rifampicin, which has already been, expanded use for latent TB, perhaps in the future be more used for also this 4-month TB treatment. So let's delve into the pharmacokinetics of the rifampicins, which for today, we're really focusing on rifampicin and rifampicin, although there is rifabutin, but again, the focus is going to be primarily on RIF and RPT. So in terms of the pharmacokinetics, I'm not going to go into too much the details, but there's a table showing some of their pharmacokinetic parameters here. You can see that rifampicin and rifampicin are metabolized by similar pathways, although rifampicin has a longer half-life. Their effect on cytochrome enzymes, which we're going to come on to in the next few slides, are slightly different. They are highly bound to plasma proteins, and actually, interestingly, they do induce their own metabolism. So even after you start the treatment, after a few days, the metabolisms of themselves increase and can reduce their overall exposure. But it's not that we're really concerned about. What we're really concerned about with the rifamycins is their effect on enzymes and drug transporters. So as I said, they're very good at inhibiting the bacterial activity, but the downside is that they really induce enzyme activities and transport activities, specifically the hepatic phase 1 and phase 2 metabolic enzymes, such as cytochrome P450s and the UGT enzymes. But in addition to the enzymes, they also induce enzyme transporters, either influx or efflux transporters, which can also have a significant impact on the availability of drug in the systemic circulation. However, each of the drugs' ability to induce enzymes or drug transporters, I see is different. So rifampicin is actually seen in terms of the CYP450 enzyme induction to be the strongest, and then rifampicin and rifabutin. So depending on which drug you give, obviously then the impact of the enzymes and etc. may be dependent on the drug and what drug is given with it. But in generally, the rifampicin is a stronger inducer than rifampicin. And if we look at the impact on drug metabolism enzymes, clearly if the rifamycins are really impacting the cytochrome enzymes and UGT, which are mainly hepatic enzymes, you can see that CYP3A4 on the top pie chart here is the main enzyme for cytochrome, and for below the UGTs and the main phase 2 enzymes. So when we're looking at the potential for drug-drug interactions, if you have a drug which is metabolized by CYP3A4 UGTs, because the rifamycins are going to perhaps induce these enzymes, there's going to be perhaps a potential issue. And when you think about that in terms of this presentation, we're going to be talking about antiretrovirals. And here in drug-drug interaction language, in this case, the drug-drug interactions are with antiretrovirals is the victim drug. So this is a drug which is metabolized by, for example, CYP3A4 or UGT, but then you add rifampicin on top, which is an inducer of these enzymes, and then that's the perpetrator, and then it can have an effect on the victim. So a lot of the examples we're going to be giving on the next few slides is that the antiretrovirus is the victim, and the rifamycin itself is the perpetrator having an effect. The vice versa can also happen, but in the situations we're discussing today, actually none of the antiretrovirals have a real impact on the rifamycins. So this is the sort of dynamic that we're looking at today. And just to put in a sort of, simple cartoon idea, this concept here, we have the liver cell, for example. We have drug A here in the top left, which is normally metabolized to its metabolite by the enzyme CYP3A4. And then we add on another drug, in this case, drug B, which is potentially rifampicin. And then that's the victim is drug A, the perpetrator is drug B. And then because you add the perpetrator, what that does is induce the enzyme. So it starts to increase the number of enzymes by transcription and, more protein, more enzymes to metabolize the drug faster. And therefore you have faster metabolism of that drug. And consequently, drug A systemic concentrations might be lower than what you would expect at that dose, and therefore, giving issues for efficacy. So that's what we are talking about, antiretrovirals specifically with TB medications, and specifically the rifampicin and rifabutin and rifampicin. But in addition to the enzymes, and this is a little bit of a busy slide in terms of drug-drug interactions, we also have to think about drug transporters, and what drug transporters are critical in getting the drug, for example, an oral drug, into the systemic circulation, often via the liver. And you can have efflux transporters or influx transporters, where, which is responsible for carrying the drug across these cell types into the systemic circulation or out into the, through the elimination pathway. And we don't expect everyone to remember all of these different names, which one is an efflux transporter, which one is an influx transporter, and what their role is. But the concept I want to highlight here is that in addition to the enzyme induction, even for a drug that is not metabolized in the liver by cytochrome enzymes or UGTP, there can still be drug-drug interactions, and this is primarily driven through drug transporters. And again, I don't expect people on a general in their clinics to remember all of these drug-drug interaction. And of course, I suspect some of you already use some of these tools that are available online to look for drug-drug interactions. For example, the quite well-known one is perhaps the HIV drug interaction website at the University of Liverpool, where they have one specifically for antiretrovirals, as well as more recently the hepatitis C drugs. There's other websites in UCSF and WebMD, where you can put in some different drugs and look, and they will try to give you, if the data is available, an expectation of the drug interaction. But clearly you want to look for drugs which are contraindicated first, and then some advice whether some dose adjustment is necessary. So let's delve in now to some of the PK considerations when trying to treat individuals co-infected with HIV and tuberculosis. And I just put a little bit of a star on this slide because I picked out, and there's many different drugs we could have picked, but due to the time frame, I've picked only a few. And I've actually focused on perhaps some of the newer drugs, for example, Dolutegravir and TAF, which I know from our experience in Thailand are not widely available yet in Thailand, but hopefully soon. And this is just to give you expectation that these drugs will be rolled out soon, and then you will have this clinical need of knowing about interactions between these drugs in the setting where TB treatment is still common, specifically in this population. So if we look at the first drug interaction, where it's really the one that's been around for a long time, which is efavirenz. So as part is tenofovir, 3-TC or FTC with efavirenz, where the standard dose of 600 milligrams once a day with TB drugs has been studied extensively. This is a meta-analysis or systemic review on the right here, which loads many different studies in South Africa, some including Thailand, which have looked at the interaction. And basically there is an interaction, but not deemed large enough to warrant a dose adjustment. So actually there is a lot of data which supports, and I'm sure you've probably treated individuals with the standard dose of 600 milligram efavirenz with the standard TB treatment. But actually in Asia, there is a specific caveat, because it's often that, it was found that the 600 milligram dose of efavirenz produced, a higher than expected toxicity. And there's studies of 400 milligrams of efavirenz were, more found to be equivalent to the 600 milligrams. So the question then was, could we give 400 milligrams of efavirenz with, rifampicin? And that study is being done. And as we'd expect, the rifampicin does reduce efavirenz concentration still, like it did with the 600, and it's still getting close to this minimum threshold, which you see here on the right. But nevertheless, the impact was still relatively low, 9–15% lower in terms of the PK parameters. And looking at the clinical, the virological response, all of the subjects, maintain biological suppression, perhaps being very close to this threshold. So again, it looks like with efavirenz, whether it's the 600 milligram or the lower 400 milligram once a day dose, co-treatment with for TB with rifampicin, seems that no dose adjustment is necessary. And I think there's quite a lot of experience in Asia with this regimen and these two doses, and it's been pretty successful. But then moving forward, as guidelines are changing, the WHO are changing now to use dolutegravir. What about dolutegravir with rifampicin? So if we're looking at how it's metabolized, dolutegravir is metabolized by UGT and a minor pathway CYP3A4. And we know that rifampicin can affect these pathways. So what this study is showing here on the top left here, where normally dolutegravir is given 50 milligrams once a day, and that's this line here, which I'm plotting here. But it also, in certain situations, if there's concerns about drug resistance, you can give 50 milligrams twice a day. And this is what happens when you give 50 milligrams twice a day. And if you add on rifampicin at the standard dose, you see this 50 milligram twice a day is shunted down to this exposures here, which actually you can see overlaps the standard 50 milligrams once a day regimen in the absence of rifampicin. So what you can say with dolutegravir and rifampicin, there is a pretty significant drug-drug interaction. And instead of using the standard 50 milligrams once a day, switching to the 50 milligrams twice a day seems to overcome this interaction with rifampicin. So I think that, and this has been used quite widely in adults, so that during the period where you have to treat with rifampicin, doubling the schedule, so 50 milligrams twice a day instead of 50 milligrams once a day, is sufficient to overcome this interaction with rifampicin. And then I thought, okay, well, let's have a look at a similar drug, another integrase drug, bictegravir, which I know in Asia is not yet perhaps widely available, and it's within a fixed dose combination, but may be available moving forward. But again, just of interest, you see that it's similar to dolutegravir. It's metabolized by UGT and CYP3A4. And actually, you see with a single dose of bictegravir and rifampicin, the bictegravir AUC is reduced by 70%. So then if they tried the same logic, try to, instead of giving, the dose once daily, you switch to the same dose twice daily. But in this instance, despite the fact that, they're metabolized by the same enzymes, here you can see that they don't overlap. So just increasing the dose to giving it twice daily versus once daily was not sufficient to overcome the interaction. So here, twice daily bictegravir did not overcome the drug interaction with rifampicin. So here we have two integrase inhibitors actually metabolized quite similarly through similar enzyme pathways, but where one intervention of doubling, increasing the number of doses per day worked with dolutegravir, but it didn't work with bictegravir. And this is why perhaps, predicting drug-drug interactions is somewhat difficult, although there's many modeling techniques. Nevertheless, doing the studies still shows that it's important to, document what exactly is happening with the drug-drug interaction. Now looking at another drug that is going to be widely used, or already widely used, is TDF in Asia, but perhaps moving forward, the new prodrug of tenofovir, TAF. And this is because while TAF is not metabolized like, through an enzyme pathway, it is a substrate for drug transporters. So therefore, although like dolutegravir with the enzymes, TAF is a potential victim of interactions with the rifampicins due to their interaction with drug transporters, not with enzymes. So here, if we look at a study of TAF with rifampicin, and this was in healthy volunteers with TAF adding on rifampicin, you can see that the TAF exposures in the plasma actually reduced by around 55%, while for tenofovir, it reduced by 54%, quite similar. But with TAF, the advantage of TAF as a prodrug is twofold. You're giving a lower dose actually compared to TDF, But actually, by giving this low, despite the lower dose, it gives much higher intracellular concentrations of the active drug, which is tenofovir DP or tenofovir diphosphate, inside the lymphocytes. So actually, the next question is, yes, we're seeing this reduction in TAF and tenofovir plasma levels with rifampicin, but what about in terms of the intracellular concentrations of the active drug tenofovir diphosphate? And here they actually looked at the intracellular tenofovir diphosphate concentration in PBMCs. This is along the y-axis here. And the first 4 bars really show TAF, tenofovir diphosphate concentrations in the absence of rifampicin. And then you can see when you add rifampicin, the levels go down. So it's there is still reducing the, compared to no rifampicin, the level of intracellular diphosphate concentrations. But when you compare to just TAF in the absence of rifampicin, just the normal TDF, dose with the intracellular concentrations here, despite the fact that you have TAF with rifampicin, you still have basically 4 times higher intracellular concentrations compared to when you give TDF without rifampicin. So yes, there is an interaction in the plasma and intracellularly, but the question is, the real active drug is still not that, it's still much higher than what you would get if you're just giving standard TDF. So although it is contraindicated in the package insert, perhaps this data intracellularly, perhaps further study of TAF when co-administered with rifampicin in patients with TB and tuberculosis. And that's really just looking at the active drug at the site of action. I'm sure some of you are thinking about long-acting drugs now. At the start of this year, the cabotegravir was approved, long-acting cabotegravir and rilpivirine. And here we've had some drugs interaction study already before it was approved of cabotegravir. And as cabotegravir is metabolized by the enzymes which rifampicin, induce, we do see, unfortunately, a large decrease in cabotegravir, this purple line here given with rifampicin, compared to without rifampicin. So this is indicating that it's unlikely that these 2 drugs can be given together, especially given that it's in the format of a long-acting drug. And there has been some simulation studies where they looked at what would happen to cabotegravir concentrations and rilpivirine when given in the long-acting form. With if you added on rifampicin, you can see that the concentrations of CAB and rilpivirine would be significantly reduced, and you can see here on this, the concentration would suddenly with cabotegravir when giving with rifampicin would decrease quite a lot. So again, although there were cabotegravir long-acting was approved earlier this year inside the package insert, rifabutin and rifapentin and rifampicin are contraindicated. So moving forward, there's been a lot of discussion now about the PK/PD of TB treatment. So, and we've seen we can now shorten the TB treatment from 6 months to 4 months. And there's been this, this has been a large part of also TB treatment, but also for the treatment of latent TB. So how high can we increase the doses of rifampicin and rifabutin to try to shorten these treatments? And this has been a big, research topic over the last few years. Can we go higher than the 600 milligrams to try to help reduce the treatment duration? Same for rifapentin when looking at the, treatment and latent TB treatment. How high can we go in terms of, allowing, without going too high to cause safety concerns, but trying to give higher doses to reduce the treatment duration? But this brings from a pharmacological standpoint a question about, well, if you're increasing the dose, how does this impact, the enzyme induction, which we've just been talking about for the drugs that we've discussed? So is it going to increase the enzyme induction? Do we have to repeat these drug-drug interaction studies? So if we're going higher rifapentin, higher rifabutin doses, what does this mean in terms of enzyme inductions? And there has been some studies looking into this, about perhaps there's an indication that despite going higher rifapentin doses or rifabutin doses, maybe you reach a maximum and then increasing the dose further than that doesn't actually have a huge effect. And there has been some studies already where at these higher doses, for example, here in the study we talked about earlier with rifapentin and moxifloxacin, with high dose rifapentin with efavirenz, even despite this higher dose of rifapentin, the impact on efavirenz concentrations were minimal. So high dose rifapentin had minimal PK, so impact on efavirenz. So, giving these 4 months treatments with this high dose with efavirenz does not seem to have a major impact. But this is a very nice study, which is looking at high-dose rifampicin in HIV-TB co-infected patients, which was presented at CROI earlier this year. And what they looked at 2 doses of rifampicin, 10 milligrams and 35 milligrams per kilogram. And they, in individuals treated with HIV with a dolutegravir-based regimen using the 50 milligrams twice daily, or efavirenz at the standard dose. And they compared the antiretroviral levels either with the 10 or the 35 milligram rifampicin dose. And what they found here, shown on the left, is with efavirenz at mid-dose concentration, yes, this is the rifampicin 10 milligram per kilogram, but with 35, the levels of efavirenz mid-dose concentrations did go down. Although they do say that there was no significant difference in the number of individuals dropping below the target threshold. In fact, there was already some here, but none here. But it looks, the variability looks X, but overall, clearly there is a shift, perhaps, but not a shift deemed significant enough to have a clinical impact. Similarly, for dolutegravir, there's a similar trend. At the higher rifampicin dose, there is lower concentrations of dolutegravir, and some dropping below what they would call the defined target. And now the impact of this was unclear clinically because none of the subjects who had concentrations or DTG concentrations below this target, had any issues with virological failure. So it's interesting that, again, with these higher doses of rifampicin, you are seeing a more of effect on the antiretroviral concentrations. And clinically, it does not seem, at least with efavirenz dolutegravir in these 2 studies, that it has a major impact clinically. But what's also encouraging that in this study that they did look at these higher 35 milligram dosing in terms of safety, actually there was no increased risk of grade 3 events compared to the lower standard 10 milligram per kilogram dose. So the last few slides, I'm going to talk about latent TB treatment, 3-HP and 1-HP. And of course, the 3-HP now is being rolled out, but the question in terms of antiretrovirals is if you have someone on perhaps going to be moving forward the most common regimen of TDF, FDC, dolutegravir, can we use 3-HP at the same time? And this study looked at that question and found, yes, 3-HP was well tolerated with dolutegravir-based ART, but the concentration of DTG were reduced quite significantly in terms of AUC. But again, in terms of clinically and virological response, it was very good. And the viral response during this, 12 weeks of treatment was not affected. So despite these lower concentration of dolutegravir, the conclusion was dolutegravir can be co-administered with 3-HP without any dose adjustment. What about finally 1-HP? We've seen 1-HP now being used, and perhaps in some cases, perhaps maybe preferable to the 3-HP, but we have to look at the drug interaction of now giving these high dose rifampicin daily. This is a study with efavirenz, and again, actually with efavirenz, as we've seen with the other drugs for treatment and for 3-HP, the impact of the rifamycins on efavirenz seems relatively low. And again, 1-HP can be co-administered with efavirenz without any clinical meaning reduction. So that's encouraging if you wanted to give 1-HP with efavirenz. But I think the next question I think you're going to be asking, and I don't have the answer, is what about 1-HP with dolutegravir, which may be being rolled out across Asia soon. And in fact, I don't have the answer to that. And there are some studies planned in Asia where they're going to be looking at 1-HP levels with dolutegravir to see, as they saw with 3-HP, can you give dolutegravir with 1-HP safely? So, hopefully we'll get that data later this year or early next. So in summary, we can see that the use of antiretrovirals and TB drugs at the same time can be challenging due to the induction of metabolic enzymes and drug efflux transporters of rifamycins, particularly perhaps on efavirenz, not so much, no issues. Dolutegravir, bictegravir seems an issue, cabotegravir seems an issue, and TAF, for example, while the intracellular levels look good, perhaps there's some concern that maybe it may not be appropriate, and currently it's not recommended. But again, more studies are needed. So it is quite challenging to find the optimal regimen with the drugs that you want to give, whether it's for treatment of TB or latent TB. And clearly one for the latent TB, and as I mentioned, we really want to look at the drug-drug interactions for high doses of rifampicin and rifampicin. For the treatment, for example, I highlighted 1-HP for DTG. That's an important research question that hopefully we'll have answers to when that's moving forward in the future. We need to refine the PK/PD, which I haven't talked about for drugs for MDR TB, because I think that's an increasing problem in Asia. But I wanted to highlight that as a research topic. And of course, drug-drug interaction studies in children, as well as actually, you know, child-friendly formulations for antiretrovirals and TB are rapidly needed. And again, when thinking about drug-drug interactions, if the drugs aren't available, you know, then the formulations are available. We really need to know what would be the optimal regimen to give for this co-treatment. And with that, I'd like to thank you for your attention.